Hello, dear friends. Um, last video I was on, uh, this one, uh, cognitive disorders, dementias, and I done previous one on stroke. So I wish to go to the third commonest neurological disease. Which everybody knows it can't be anything other than epilepsy. Epilepsy means seizure. Epilepsy. Something falling on you or catching you. Seizure. What is seizing? It used to be thought that some devil is seizing. Even in our native language like Malayalam, Sanskrit, and all that, it didn't have any any good association. They used to say apasmaram. Apa means bad. Smaram again maybe is seizure. So apasmaram actually means the person has become something else. That's what's happening in epilepsy. The person either partially or completely loses his consciousness, and he has what's called automatisms. Automatism is something, you without your control, your hands or your legs or your feet go into spasms, or sometimes it goes into some stiffness called tonicity. What happens in tonicity is, the tonicity is actually the contraction of the muscles in good tone. So both the flexor and the extensor muscles flex, that is contract simultaneously. So they will go something like this, stiff, become stiff. So that stage will last for a few seconds or 1 minute, usually less than 1 minute, because during that time they may not be breathing. So if they go on or something blocking the respiratory passages, the patient could very well leave this world. So it doesn't last that long, fortunately. And then they will have they had this like that. Then after that, the spasm will go, and then it becomes something like this one, like this, like ejaculation. It's called clonus. This is one of the typical seizures. Then along with this clonus, just after the clonus, they will start breathing normally and go into a brief period of consciousness or altered sensation or headache, or they pass urine. It's quite common. And they would have bitten the tongue. But getting bitten on the tongue is by no means sine qua non for epilepsy. Even people who fall, the most common differential diagnosis is stroke. Even if people fall, they can have this thing, tongue injury. But there is one one differentiator which could be that the tongue injury in seizure may be on the lateral side, that is on the side of the tongue, whereas this one in epilepsy or seizure, I hope everybody likes the word seizure. There is no other word, seizure or epilepsy. The common word is fits. So the tip of the tongue would be injured in fits, whereas in fit means it's a kind of dangling or stationary consciousness. Fit in a fit of rage, in a fit of this thing, that's it, like that. So fits. not fits or seizure. Seizure is better. Seizure is better. There is no. If you can remember fit, you can very well remember seizure also. So that is what's called, used to be called grand mal. Grand mal or the big seizure. Grand mal may be disease, so big disease, big. But nowadays, the neurologists and all the doctors try to avoid that term grand mal, because the later classification is called a generalized seizure. Generalized seizure because it affects every part of the brain, the left, right, the cortex, the subcortex, the deeper brain structures. So everything is affected. So that's why it's called a generalized seizure. As opposed to something which is called focal seizure. Focal means there is a focus. There is a small area on the cortex, or maybe in some part of the lobe, temporal lobe or occipital lobe, where the by the way, I forgot to say that the seizure is a storm in the cup. In this one, it is called kapalam or kapalam in Sanskrit. The head is called kapalam, and from the kapalam has come the kopa, then which became cup. So it's a storm in a cup of the human head. So what is a storm? It is a synchronous electrical activity of the brain. So electrical activity is there usually, and it is actually directed towards specific purposes. But if all that thing goes, I think the appropriate term is go haywire. But actually it's not going haywire. They're synchronized. They're grouped together. The firing of all the neurons in the cortex and subcortex group together, and then they produce all the various manifestations of the grand mal. And if it is the focal seizure, what will they have? Depending upon where the focus is, they will have that particular kind of seizure. For example, if it's in the parietal lobe, or that is the side part of the brain, parietal brain, which contains the motor cortex. Motor means muscle movement cortex. They will have, if it is on the left side, they will have a movement of the right leg or arm, most probably arm, because in the homunculus, that the hand area is represented more. So it's more likely the hand movement will be there. The automatism of the hand will be there. They will slowly move the hand. That is called focal seizure. So suppose it's in the temporal lobe on the left side, it is language is there. So you may not be able to speak, language area is there. Then there is an area of memory is there. So person will be in a kind of fugue. It's called fugue. That is, there will be memory loss can be there. So if it's a occipital area, visual area is there, so they can have vivid, colorful hallucinations, this visual hallucination, colorful visual hallucination. So depending upon the area where it is, the manifestation will be in consonance with that area. So in old people, why is it important in old people? Because the incidence of epilepsy jumps from 1 to 2 per 200 people throughout the world, from 40 years to 60 years. By the time the 80 years, it becomes 3 per 200. So there is a twofold, threefold increase as you grow older. Why is it happening? Because of the structural damage when you grow old. And most of the structural damage in old people is because of the cerebrovascular disease. Cerebrovascular disease, hypertension, the stroke. The stroke is one of the common causes of seizure. There is a peculiar thing called stroke associated not stroke associated. Yeah, stroke associated hand movement. That's called shaking limb TIA. Shaking limb TIA. The person will shake. You think it is an thing. It's a seizure, local seizure, or focal seizure. Focal seizure can also be called partial seizure if you don't lose the consciousness. If you lose the consciousness, it becomes complex partial seizure. So these are some other descriptions. Partial seizure. We can also say localized, generalized. Doesn't matter. Same meaning. So, but by convention, we say partial seizure, complex partial seizure. Complex partial seizure means the temporal lobe mostly complex partial seizure, in the sense that they lose their this one Stalagala thing, gnosis, dhanam. They lose that the environment. The memory and all those things will be lost. So this shaking limb thing is shaking limb TIA. TIA means transient ischemic attack. Is usually TIA can be differentiated from stroke very easily, because TIA generally produce negative symptoms, negative symptomatology or the phenomenology. Negative symptoms, they will have loss, paralysis of a limb, or some eye will be tosses of the eyes, things like that. Whereas in stroke always there is a positive symptom, the movement is there. And of course, after this thing movement, they will have what's called everybody knows it, Toad's paralysis. That is a post-ictal. Ictal also same thing, means seizure. Ictus. Ya means throw. Ictal. Post-ictal phenomenon. Post-ictal phenomenon. It's usually in children with all these things. So by concentrating on the old people, and because they have a lot of these things, pathology, I said cerebrovascular, then they have the thing neurodegenerative, like dementias, Alzheimer's, and all those things. They may have more incidence of tumors, infections, especially herpes simplex infection or pneumococcal meningitis, notorious to produce seizures. So this is something about classification and how you diagnose. You can't misdiagnose, but in old people you are not sure, because there are so many things which come just like seizure. Absent seizure. Absent seizure means actually it's pronounced as absence. It's French word. Absence means actually they are absent, in the sense that they are in a kind of fugue. That happens very often in old people. We can even say that's kind of differential diagnosis for delirium. Sometimes delirium differential diagnosis. Then there is something called amnesia. Amnesia also common in old people. There is an epileptic amnesia there. Transient epileptic amnesia, where they will have, they lose the memory for some time. And they are looking here and there, where am I? And one peculiar feature is that lose their autobiographic memory. They won't know who he is, what is happening. So that is called the epileptic amnesia, transient epileptic amnesia. There's one more called global epileptic amnesia. Global epileptic amnesia means actually they will be in a kind of fugue, loss of memory, complete loss of memory. But they may be able to do some cognitive tasks during that period. But later on they will not remember what happened. Usually lasts less than one day. That's called the global amnesia, epileptic global amnesia, but it's actually not because supposed to be not because of epilepsy, but because sometimes after a severe exertion you do a long distance running. So the old people are doing a long distance running. This is possible. What happens is that jugular venous pressure goes up. So that will have a back pressure on the brain, and the brain will start swelling. That's called a global amnesia, global amnesia, and a transient epileptic amnesia. So different kinds of transient epileptic amnesia is any number of things. Suppose you have a psychiatric problem, you remember, but very easy to differentiate in the sense that in psychiatric kind of amnesia, they will think that they don't remember anything about them. They don't remember any place. They don't remember the autobiographical history. At the same time, the short-term memory will be preserved, so you can catch them very easily. So in the sense that you tell them a word, and then you ask them, what did I say just 5 minutes ago? They might remember. So that is, I can't say it is malingering, but it's a kind of dissociative state. Psychiatry will say dissociated. You don't associate with that particular incident. That is, it may be unconscious, not consciously, but unconsciously. That's called dissociative state. Actually, what we used to call hysteria is a kind of dissociation. So these are some of the pitfalls in diagnosis. But always take an EEG. EEG will tell you whether it's a fit or not. If it's an epilepsy, they will have some spikes in the EEG. You know EEG, isn't it? Where there are two lines where they put about 8 electrodes, and then the difference between the two electrodes here, that comes as a wave. The potential difference between them. And where there is epileptic activity, suppose there is epileptic activity in temporal lobe, they will have this thing, that particular locus of electrode will show spike. There is in young children there is something called abscesses. It used to be called petit mal, the small mal, petit mal. In petit mal they have a particular waveform in the EEG. It's called 3 per second spike and a wave. Actually, I was seeing an American physician describe, who does research in this. Actually, it's an old video, but he describes it very well. His name is, I just forgot the name. If you search the net, you will get. So that EEG diagnosis is there in that. So EEG is quite useful because sometimes even during the seizure you will get a wave, but even during the interictal, that is interregnum between two episodes, you will have some changes, some smaller wave changes. So you can see that. But there is something called psychogenic epilepsy. So in psychogenic, it's very difficult to differentiate. They will have all the features of real epilepsy. And if you are overconfident of your EEG, sometimes you will make a diagnosis of real seizure. So you have to be careful. So actually, epilepsy is a clinical diagnosis. It's not an EEG diagnosis. The EEG is just helpful. But what is more helpful is during the period of the seizure, and at the period of the seizure, you can take what's called a video EEG. I don't know if it's available in Kerala, so just got for the textbook. Maybe some centers having video EEG. They will take a video of what the inspiration, the strider, and all those things, and how they move, and get a good picture, and connect it with the EEG. That's called video EEG. That's supposed to be a gold standard for diagnosis. And of course, for structural lesions, for old people, CT is okay. provided they don't have renal failure. By the way, renal failure can actually anything can cause a fit, but this electrolyte abnormalities, renal failure, hepatic failure, all these things can cause with hypoglycemia, hypoxemia, you name it. So anything can cause a fit. But one fit may not be enough to make a diagnosis. But one fit with EEG changes definitely seen. And on the long-term effect of fit is that they will have intellectual disability. Then the societal stigma is there. May not get a driving license. All these things. And but so making a diagnosis, MR, if you want to do an epileptic surgery, you should get an MR. MR will tell you where exactly the focus of origin of this thing. In old people, it's always localized, but I don't think any old man will want to do an epileptic surgery, except for perhaps in meningiomas and things like that, which easily comes out. And so most of them would want to do a CT because easy to do. For MRI, you have to be in that gantry for about 10 minutes. Wherein CT nowadays, that the higher slice CTs are very fast, and radiation dose is also low. So CT, multi-slice, MDCT, multi-detector CT, would be the gold standard for diagnosing this thing, plus EEG, plus all the things, usual stuff, the blood parameters, the electrolytes, whatnot. So, but the thing in treatment, I've always try to, if there is anything which stimulates or which predisposes to an epilepsy generation, like insomnia or something. Some people have some idiosyncratic, this idiosyncratic thing which will generate epilepsy. So you try to modify that. For example, if you are an alcoholic or you use some drugs, try to stop doing that. And then the main thing is the drug treatment. Drug treatment is very, very good, very effective. There are two kinds of drugs, the old ones and the new ones. New one means it's not so new. It's since 1980. So they are called a new class of thing. The difference is that, this old people may not tolerate the old ones because the old ones are highly, protein bound, and they will induce osteoporosis because they will interfere with the absorption of vitamin D and all things like that. Or some drugs, actually, for example, sodium valproate, it will interfere with the osteoblastic activity. So they can induce osteoporosis, then a lot of obesity, fat will be laid in. So that's old anti-epileptic drugs, but still they are useful, like Eptoin. A lot of side effects are for Eptoin, and nowadays people don't use that. I don't know what you guys are using, but generally nowadays they use the two mainly for generalized epilepsy. If the people don't tolerate sodium valproate is supposed to be standard for generalized epilepsy. People will give what's called levetiracetam. It's a derivative of the old piracetam drug, levetiracetam, but supposed to be very effective. It can even be given for status epilepticus. So I forgot to tell you that why epilepsy is dangerous is because the people with epilepsy goes into what's called a status. They will have continuous epileptic activity for more than 30 minutes. Either one episode or 2-3 episodes, but without any interictal period, more than 30 minutes becomes a status. Status is high mortality there. So you have to treat status generally by giving diazepam. Two types of status will be there. I said generalized two types are there. One is the tonic clonic, or the tonic or the clonic or whatever. There is something called absence. So the status can be absence or the tonic clonic, generalized. For generalized, you have to give diazepam. Or if you don't respond to diazepam, give them phenytoin, IV infusion. IV infusion, and always taking cognizance of the respiratory depression that might ensue with all these sedatives. And keep them under observation for 24 hours. And give them a good loading dose of phenytoin. Nowadays, because nowadays people will give levetiracetam, IV infusion. Maybe I'll give around anywhere from 1 gram to 3 gram, I think. And for focal epilepsy, the drug choices used to be carbamazepine. Again, carbamazepine highly protein bound and lots of things. So either you can give this one, what's called lamotrigine. Lamotrigine is supposed to be good for focal epilepsy. It's a sodium channel blocker. And or you can give pregabalin. Pregabalin is also highly effective. Not gabapentin. Gabapentin may not be that fast acting. But pregabalin is fast acting. You can give. But dosage is not the ones you give 25, not 25 milligram. You have to give maybe 300 milligrams, something like that, for saying localized epilepsy. Focal epilepsy, or general epilepsy. These are given for all kinds of things. If it does not respond, you have to add something else. But addition may be more toxic. So try to be one as far as possible, but titrate this. So that's in short, right through the epileptic seizures, and in old people, why it's the focal epilepsy, because of structure damage because of this thing, and why it is more common, mainly because of the cerebrovascular accidents, which maybe he might be conscious of it or unconscious of it. Sometimes the person may not have known that he had a stroke. Only MRI will tell he had a white matter lesion, things like that. Or dementia can produce stroke. And you might think people are having this thing, delirium. If you think delirium is not responding to usual management, like familiarity and treating infections and all those things, always consider this an epilepsy, status epilepsy, absence seizures. Take an ECG, EEG. By the way, ECG also you should take, because the commonest differential diagnosis for stroke in old age is, epilepsy in old age is this one. Syncope, fall. So you have to take an ECG in all cases, along with EEG. Before EEG, you can get an ECG. Let's look for contraction abnormalities. Okay, I'm not stretching it any further. Thank you for your patient hearing. If you think it is useful to somebody, just pass it on to, especially the senior folks. Thank you once again.